Okay, all right. So, hi everyone. My name's Tom. I am an Obs and Gynae trainee. This is a presentation on behalf of our team at Queen Charlotte's and Chelsea Hospital, which is part of Imperial. We're based in London, and we chose to do a project on postnatal hypertension. Next slide, please. So, a little bit about why we chose postnatal hypertension. Postnatal hypertension is a very important, often overlooked problem that has many areas that it impacts, including longer stays for patients, increasing travel time, often polypharmacy for patients with lots of different medication for infrequent amount of time. It has incredibly important implications for future cardiovascular health and is also recognized to be a large inequity issue. So, looking at all of these areas, we felt that we would be able to make changes to improve both equity but also carbon emissions as well. Next slide, please. So, in terms of the impact of postnatal hypertension, so we know that increased travel time to and from hospital, prolonged admissions whilst blood pressure problems are treated, also due to readmissions. So we know that postnatal hypertension is the leading cause of readmission to hospital for women in the postnatal period, but also wasted medication and polypharmacy for patients. We know that the impact of being in hospital longer in the postnatal period with a newborn baby is very difficult for women, leading to poorer sleep, longer periods of time away from their support network, but also has knock-on impact in terms of patient flow, impacting women on the antenatal ward and also on the labour ward if there's no bed space available for them postnatally. Uncontrolled hypertension or poorly controlled hypertension leads to poorer health in future pregnancy, but also longer term with higher rates of hypertension, cardiovascular disease, and stroke later in life. And we know that also wasted medication, longer inpatient stay costs, and reduced number of years contributing to the economy would have an increased economic cost. So that's why we felt that it was a really important area to target. Next slide, please. So we did a pre-intervention survey in October of doctors working on the postnatal ward at the front line just to determine what they felt the problem was around postnatal hypertension, its management, because we were aiming to target the heterogeneity in prescribing practices and practices around how long patients were staying in for, because we recognise this as a problem as a cohort. So we found that people did not find the current guideline very useful. They found that advice they were being given was incredibly inconsistent, and they didn't feel very confident in managing postnatal hypertension. Next slide, please. They also felt that they were maybe not giving pregnant women the best advice regarding breastfeeding and their future cardiovascular risk. Next slide, please. So, just some feedback from resident doctors was that people had different ways of managing hypertension. There was a lot of uncertainty around how long patients would stay in for, and a lack of focus around patient-centered care. People recommended an improved standardized approach and simplified flowchart. Next slide, please.
Oh, sorry.
No, it's okay. So we did an audit from September to October, which involved 53 women, and we looked at key areas that we felt would be important to determining the environmental economic cost of this. So the average length of stay in our unit, which is a tertiary unit with about 5,000 deliveries per year, was 4.6 days, complicated by hypertension. The average number of PET screen blood tests, so that involves a number of different blood tests, was 5.2 per patient. We saw that 28% of patients were being discharged on more than one antihypertensive medication. 9 women came back for review of their blood pressure or as an acute unplanned admission. And 3 of these women were actually readmitted to the postnatal ward with an average length of stay of 1.5 days. Next slide, please. So this slide hopefully just gives you an overall. You can see that lots of different medications were being prescribed. It was very inconsistent and very different across the board. So next slide, please. We had some patient feedback. Obviously, the postnatal period is sometimes hard to get patient feedback because people are keen to get out of hospital, and also in the first few months are often incredibly busy with a new one. So this we did some informal feedback from patients through emails and collecting sort of verbal reports they were happy for us to share. So patients talked about the fact that they were being seen by lots of different people with lots of different plans, with lots of lack of consistency. People were desperate to get home, struggling with the being in a ward, a bay with lots of different babies crying and having poor sleep. Next slide, please. So we actually we had an MDT discussion. So it's an obstetric medicine unit. So we have obstetric medicine midwives, specialists midwives in obstetric medicine. We also have lots of obstetric medicine physicians at the unit, and it's a tertiary unit for obstetric medicine. So we felt that we had a really good team to be able to advise on changes around this, and that actually we should be managing this a lot better. So we had an MDT discussion. We also had a discussion with a GP who's lead for maternity and newborn care in Northwest London. And we did a literature review to look at postnatal hypertension, how we can improve it, and what changes we could possibly make. We presented this at a maternal medicine network meeting for Northwest London, and we came up with an improved, streamlined approach to our current guideline, and we placed nifedipine as our first line agent for managing hypertension postnatally. And NICE gives you the option of lots of different ones, but we felt overall this would offer us the best control, quickest control, and hopefully lead to patients being discharged on just one or two agents. And we also clarified the number of blood tests that were needed and discharge criteria. Next slide, please.
Just to let you know, you've got about 30 seconds left.
Okay, right. Let's just go. So we showed that we dramatically reduced the length of stay to 2.9 days. There were fewer blood tests. No patients were discharged from more than one medication. No patients came back. So maybe I should go to the results slide at the end quickly. So
Keep going.
yeah, keep going all the way to the end.
Sorry.
That's fine. So we re-audited and we resurveyed our doctors, and overall we've shown that we've had a dramatic reduction in postnatal length of stay, which has led to sort of our findings extrapolated over a year, leading to a reduction of 173,000 miles equivalent driven per year. We've also cost saving just from medication and blood tests, not from inpatient stays, of £4,500 a year. And we have had some feedback that we have increased consistency in care. I'm going to stop there because I know I'm out of time, but obviously I could talk forever.
Oh gosh, sorry. Thanks. I'm really sorry to rush you. The end.
No, it's fine.
Any questions from the judging panel?
That was a wonderful presentation, and I think quite appropriate, because we do tend to see a lot of unnecessary blood tests and medications that you showed, multiple medications. So a really good presentation. How did you manage to get everybody on board? Because you seem to have done quite a good job with that. This is the hardest bit in hospitals, isn't it?
Yes. I think we've been talking about changing postnatal hypertension at Queen Charlotte's for a while, and then it was the Green Maternity Challenge gave me the opportunity to make that change. We had a consultant who's a maternal medicine physician who was very keen to make the change. So we worked together, I think, and we had lots of informal discussions with people before we brought it to the wider MDT, and we went very prepared with literature review results, and we had already prepared our streamlined guideline approach so that people could review it, and then that way we were able to make the change happen just from maybe a couple of presentations and a couple of meetings, rather than having lots of extended meetings because of the project timeline overall.
Great. Are you going to use the same methodology for other conditions?
I think it would be, I mean, it would definitely be a good idea. I think some are better managed than others. So, one of the key things that we found is that, for example, gestational diabetes is better recognized in general practice as a risk factor for future risk of type 2 diabetes. And GPs are very good at doing an HbA1c at 3 months and annually thereafter. And it's actually coded. But one of the big problems we recognize from general practice is that actually, at least in Northwest London, preeclampsia, PIH, postnatal hypertension are not coded or recognized as a future cardiovascular risk. So they don't score on the key risk for women in the future. So that actually the major thing we're trying to do at the moment is we're trying to, basically it's a simple change, but allow for that to be coded as a diagnosis that gets pulled through, so it flags for annual blood pressure review.
Great job.